hi everybody, and welcome to the National Hispanic and Latinos webinar. Today's webinar is titled Developing Culturally Centered Interventions for Hispanic and Latino Populations, and our presenter is Dr. Michelle Evans. I would like to let our audience know that this webinar is part of a curriculum that the National Hispanic and Latino ATTC developed along with Dr. Evans. And for those who are interested in receiving training on this curriculum, you may email us to request to. Okay, so I will tell you a bit more about our presenter soon. Okay. So during today's webinar, all participants will be muted. The audio will be streamed to the computer, so please make sure your computer speakers are turned on and off to hear today's presentation. Now I'm going to review a few housekeeping items with everyone. If you notice that your viewer does not fit your screen, you can expand it by clicking the expand button located on the top right corner indicated by the red arrow. And that's right here. Okay. Now you'll see that your viewer is expanded to fit the entire screen. Also, you can collapse the GoToWebinar toolbar on the right of your screen by clicking on the small red arrow located on the left of the toolbar. And then you can click the arrow again, and it expands or it will minimize. Okay. As I mentioned, for today's webinar, all participants will be muted. As we move through the presentation, if you have a question for our presenter, we ask that you use the chat box on the toolbar. Simply type your question and hit send. We can pause at the end of the presentation. We'll leave a few minutes for Q&A. And also for those questions, if we don't have enough time to answer all of the questions, we will post the answers on our website. A recording of today's webinar along with the PowerPoint slides will be available at our website, www.attcnetwork.org/Hispanic Latino, approximately 1 week from today. You can also find recordings and PowerPoint slides from all our past webinars at the same URL. One NADAC, one NVCCA, and one ICNRC continuing education credit is available to those who attend today's live event. So if you're interested in obtaining CEUs from these organizations, please email us at hispaniclatino@uccaride.edu. Today's webinar is sponsored by the National Hispanic and Latino ATTC. As of October 1st of 2012, the network has been restructured and now consists of 10 regional ATTCs, 4 national focus area ATTCs, along with the network coordinating office. As you can see by this map, the ATTC network regions were realigned to better fit the current HHS regions. And you'll find that we have the 4 national focus area ATTCs listed on the left. Today's webinar is the 25th in a series that the National Hispanic and Latino has been offering. The ATTC network is funded by the Substance Abuse and Mental Health Services Administration and serves a critical role in improving the health of the U.S. The network achieves this by translating, disseminating, and promoting the adoption and implementation of evidence-based clinical practices and strives to improve the health and wellness of individuals whose lives have been impacted by substance use disorders. You can learn more about the network's products and programs by visiting attcnetwork.org. As I mentioned, the ATTC network is funded by SAMHSA. SAMHSA strives to reduce the impact of substance use and mental illness on America's communities through its programs and services and demonstrates that behavioral health is essential to health, prevention works, treatment is effective, and people recover from mental and substance use disorders. Again, you can learn more about SAMHSA by visiting www.samhsa.gov. So now to meet our presenter. Dr. Michelle Evans is a licensed clinical social worker, certified alcohol and drug counselor, and licensed sex offender treatment provider with experience in individual and family counseling and in developing therapeutic groups. She has worked primarily with the Latino population throughout her career as a bilingual and bicultural social worker. She is the Assistant Dean for Health Professions and Public Service at Wabaunsee Community College in Sugar Grove, Illinois, and an adjunct professor and researcher at Aurora University. She also is in private practice at Nickerson and Associates as a bilingual therapist where she treats adults and adolescents with mental health issues, substance use issues, and sex addictions. Previously, she held positions within public and private psychiatric hospitals. Dr. Evans earned a doctorate of social work and master of social work degree from Aurora University in Aurora, Illinois. So before we start, we're going to do our poll questioning, and we'll start now. Our first question is, do you currently serve Hispanic and Latino populations with substance use disorders? And we have 75% say yes, 25% say no. Okay. Next question. Okay. What are you planning to serve Hispanic and Latino populations with substance use disorders in the next 6 months? And 83% say yes, 7% say no, and 13% don't know. Our next question. What is your current professional role? And we have 37% social worker, 34% counselor therapist, 3% faculty research student, 6% government official policymaker, and 33% other. Okay. What type of setting do you currently work in? Okay, so we have 15% academic, 43% treatment, 1% research, 14% government, and 27% other. Okay, so now we're going to our pretest. Culturally adapted interventions allow the clinicians to use identified protective factors to enhance the impact of treatment. True or false? And 100% of participants say yes. Our next question. Culturally adapted interventions can be created using only evidence-based practices that have worked well for that population. Okay, and 47% say true and 51% say false. Next question. Current culturally adapted interventions consider the client's concept of health, distress, and cultural values when developing goals. And 100% of participants say yes. Okay, so those are our questions for now. I just want, before we pass over the controls to Dr. Evans, I want to remind everyone that, number one, that if you're interested in obtaining training on this curriculum, you may email us and request the training, and also that if you have any questions, you can use our chat box and we'll leave some minutes at the end of the presentation for questions, okay? Okay. So now I leave you with Dr. Evans.
All right, well, good morning or good afternoon, depending on where you are. I am so excited to be here today, as this is one of my most favorite topics, and just based on a couple of questions that you answered, it looks like we do have some things that we can talk about, especially regarding that second one. So in today's training, here are some of my learning objectives that I'm hoping to discuss. And as usual in my presentations, it's always a little well, it's a little eager, you know, but we'll see if we can accomplish all these things today. So first of all, I'm hoping that we'll be able to discuss the 8 areas of culturally centered interventions. Additionally, I'm hoping that you'll be able to identify specific elements of the Hispanic and Latino population which may need special attention, and that you will have an awareness of how to develop culturally centered interventions when working with Hispanic and Latino individuals. And so I should start with, you know, usually when we think about culture, it's kind of this ambiguous topic where we talk about it a lot. We talk about becoming culturally competent, and in some ways in our fields it's almost becoming the buzzword of cultural competence. If you can walk away going, well, you know, we're culturally competent here, you know, we have interpreters, or we're culturally competent, we offer our materials in multiple languages. It seems like a really positive thing. However, sometimes it's hard to know, are we actually meeting the needs of individuals from that cultural perspective? And so to start, I'd like to offer this definition of culture. And I think about it comes from the Latin to cultivate, you know, which isn't just a fixed noun. It's actually a verb as well. And when I think about even my own culture, I think about how it's constantly changing depending on the worlds that I'm living in. And even my age, you know, I continue to develop, my culture continues to develop as I age, as I grow, as I learn new things. You know, as I know many of you are therapists or, you know, in the field, and so many of you, as you've transitioned from even getting an education and becoming a professional, you too have changed cultures and are in a different culture than individuals that may be less educated, just by the sheer fact that you have knowledge or you have you use the same language that other people in your field use. And so understanding culture is just one more method to use to allow us to reflect critically and respond creatively to the change forces which impact the lives of our patients. And so one way I look at it is that with culture, it's kind of like skin. We only feel it when it rubs up against someone else's. And so therefore, when we think about culture, that's one of the most important things, is to recognize that our own culture impacts the culture of those that we're going to be working with. And so during my presentation, one thing that I'd like you to think about isn't just the culture of your clients and how to better understand it and adapt your interventions to your clients, but also consider yourself and your own perspective and how your perspective impacts your clients, and how your personal perspective and your culture impacts just the interactions you have and how people approach you and how they share culture and their cultural viewpoint with you, because that in itself can be a major barrier sometimes that we have if people don't feel that our culture and our perspective allows them to share theirs. So cultural norms are patterns of behavior that are typically noted in specific groups of people. I think about my own experience, and so I spend a lot of time in academia, but I also spend a lot of time with individuals that treat substance abuse and sex offenders and sex addiction as well. And there are two completely different types of culture. I remember feeling this most one day when I was at an academic orientation. It was a big event. I was sitting at a table and I started talking about, someone asked me about my work as a therapist, and I unfortunately definitely started talking about it. And when you're talking about sex addiction and drug addiction, it turns out that's not dinner table discussion. But I didn't figure that out until I had just said way too much, and everyone's looking at me going, wow, this is a great conversation. And so that was a really great example of culture. And even though I thought that I was sitting at a table with people that had similar education, similar, we looked similar, we behaved similarly, but all of a sudden I realized their values of what we should talk about at dinner, their attitudes and their beliefs, and certainly their behaviors were different than maybe the conversations that I'd have having dinner with some of my therapist friends. And so that's kind of an example just of how cultural norms impact us on a daily basis. And so some of the concepts related to cultural sensitivity, and so here's what we're trying to develop. Number one is one that I think that we often talk about the least, which is an awareness of ourselves and of the individual that we're treating, and also ourselves as an individual. And so if I'm not aware of my own cultural biases, or even how I do things, how I approach things, my perspective and my beliefs about illness and health, often I can miss what the person across the table, across the room, is talking about. Additionally, we have to have the knowledge of how to ask crucial questions that will help us discover the perspective of our client. And then lastly, we need the skills to know how to modify treatment interventions to increase efficacy. And I think that is the hardest one, because when we start thinking about cultural competence, often we become, or at least I know in my experience, I just become overwhelmed at how can I even begin to do this? Culture is such a big thing, touching so many beliefs and values and attitudes. How do I even start when maybe I have at most 20, 30 minutes if you're doing a psychiatric assessment? How can I be culturally competent in that period of time? A few beliefs and stereotypes of Hispanics regarding mental illness, and this also applies in many ways to substance use. Hispanics and Latinos tend to experience depression in the form of body pain, such as backaches, headaches, stomach aches. They may also describe symptoms of depression as feeling tired, changes in their sleeping or eating patterns, or feeling nervous and restless. And I mention these things because thinking about these, depression, substance use, those are things that, if we're a clinician, we look to treat the mind. How do we think better or think differently? How do we change, some of the habits that you've had? Especially we often use CBT in our work. It's very much in the head, where our client may be coming to us, saying, well, this is how I feel, and they may be expressing their feelings using words that express body feelings. And here we're looking for thoughts, and we're explaining it in that kind of terminology, and there may be a misunderstanding, and difficulty in applying this. So additionally, Latinos may believe that physical symptoms are more serious than mental health symptoms, same thing with substance use, and so often once the physical symptoms go away, we lose the client, which I know is a difficult thing in many of our agencies. They're also more likely to believe that their symptoms are caused by outside environmental, spiritual, or personal problems. I've led many social work classes on spirituality, and often, the first line of talking about it, even a MSW class, many students are uncomfortable talking about this. And I know many clinicians as well. It's a really hard thing to discuss and to approach with oneself often, or one's family, much less a client when you're not sure where they're coming from. Latinos are less likely to endorse a biological etiology of depression and mental illness. They tend to view medication as addictive and harmful. And then lastly, they may prefer counseling over medications. And those last two are really talking about how the individual chooses to get well, what methods and what interventions they feel is going to be helpful. And often if we're coming from one direction going, well, this is how we treat people here, this is, these are the evidence-based treatments that we use, we know that they're reliable, and your client is coming to you going, well, yeah, but I don't want to do that, or it doesn't work for me. And so how do we get over that and reach this person? So many of the Latinos also have strong support systems in their family, and so that goes back to their beliefs and values. What they value is having that involvement, especially, if those other family members are willing to attend appointments and be supportive. And often, if perhaps we haven't had a lot of experience with group work or family work, or, I've met a lot of new therapists who getting the whole family in the room is a little intimidating, just because now we're outnumbered. Often, you know, culturally, that's one area where we might try to avoid if, as a therapist, we're uncomfortable with that. Some Latinos may be open to a holistic treatment experience involving spirituality and physical health treatment. If positive rapport is developed, they're more likely to trust a professional and follow recommendations. And then research has demonstrated that Latinos are more likely to believe in the positive impact of mental health treatment than white, and I should say non-Hispanic, non-Latino counterparts. You know, and so here are some strengths, you know, some beliefs and values that many Hispanics and Latinos may have that can be used to develop some of those culturally competent interventions, which I'll address in a minute here. So the first thing I'd like to talk about is the impact of the concept of illness. And remember, a couple slides ago, I asked you to think about your own approach when you think about the concept of illness. And so regarding substance abuse and also mental illness, cultural competence that impact treatment may be related to acculturation, discrimination, oppression, and stigma related to substance use and mental illness. One topic that is emerging in a lot of the literature is the idea of ethnocultural empathy. And this is the idea that you can empathize with someone, you can as a human, but if you don't understand that cultural component of empathy, the cultural component that's needed in that empathy, we can be missing something, which are exactly these factors: their experience for acculturation, discrimination, and oppression. You know, regarding their own experience as a person and their experience with substance use and mental illness. If an individual is using substances, maybe an increased perception of suffering, this inability to connect with others that may be more strongly missed than in a culture that values independence and detachment. And so when we have a culture that so strongly values that familial aspect, and all of a sudden we remove that due to shame, due to stigma, due to, you know, just often when someone's using substances, they run from that family and they isolate. And that is even more greatly felt when it's an expectation, it is a value that is so strongly held. And so some of the cultural concepts of distress are that formulate our idea of what our illness is and what we're experiencing. It's expressed through three concepts. The first is cultural syndromes. So these are groups of symptoms that co-occur among individuals in specific cultural groups, communities, and contexts. You know, and so these can be things like nervios, things that are that share some symptoms with diagnosis we have in Western medicine, but might not be exactly the same. Cultural idioms of distress. Now these are ways that symptoms are expressed, which provide a collective shared ways of experiencing and talking about personal and social concerns. Different cultures have different ways to express feeling anxious, feeling ill, feeling depressed. You know, often even I'm thinking of generationally our new teenagers and our young adults. Often the first thing that we see when they're not feeling well is that they stop connecting through social media. They take themselves off the grid, you know, as I might say. You know, and this, for generationally, is something that, because it's so expected, it's something that's so valued in today's youth, it's something that it might not be noticeable for someone a little bit older in a different generation, but something that's so obvious just because for that culture, that generational culture, it's so important to have that social media presence, for instance. Also, cultural explanations, which are perceived causes. We're going to talk about this a little bit as well. And those are labels, attributions, or features of an explanatory model that indicate culturally recognized meaning or etiology for symptoms. And so this is, why do you think you're sick? Now, most of us, many of us here today on the webinar, we've been trained in a certain way of, this is how I believe illness occurs. And it makes sense for us. You know, when you walk into a room, generally, if I were to ask you, why does depression happen? You could, you know, okay, it happens because, you know, of a brain disorder, or, you know, maybe there's some genetic cause, maybe, you know, there was a trauma that happened. So that's how we walk into our explanation of how illness occurs. However, when we're working with clients, that's not always the case. They're walking in from a different perspective, and if we have our perspective and they have their perspective, it may not be wrong. what I often tell my clients is, I'm the expert over the books. You know, I've studied a long time, I've met with a lot of people. That's what I know, and I own that. However, you're the expert of you. And I can give you suggestions, we can talk, we can formulate ideas of what's going to help you, but ultimately, you are the expert of your experience. You're the expert, and I don't need you to own my explanation of your illness if my explanation of your illness doesn't lead us to interventions that are going to be helpful for you. You know, and so having that openness to begin to be able to hear, what is your explanation? How did you get here? How do you explain your illness? What are your symptoms? You know, how would your parents explain your symptoms? Many of these are questions, if you're interested in more questions, that can be found in the cultural formulation interview in the DSM-5. It's way in the back, but it's this beautiful, they outline many questions of just tell me about your experience of your illness. And tell me about your family's experience of your illness. What does your family, how does your family describe their experience with your illness? You know, what have they identified that's most problematic for them when we talk about your illness? You know, and those are ways that as you start to develop your assessment, we can start to begin to open up our options for interventions. Now, I'm not talking too much about assessment today, but of course, you know, an appropriate cultural assessment leads to a better, more opportunities for culturally appropriate interventions, you know, and so you can certainly find more about that in that cultural formulation interview. It's wonderful there. So discussing beliefs about the origin of illness is important. So there are three primary belief systems of the cause of illness: personalistic, naturalistic, and biomedical. I'm going to describe them briefly here. So within a personalistic system of beliefs, the individual may believe that their illness was caused by the intervention of a divine being with special powers, maybe caused by retaliation for sins, disrespect, maybe believed to be caused by bad luck or karma. Recovery entails the use of ritual and symbolism, often by natural and spiritual healers. Now, this is often also used within we can hear this even within a Western environment, of people going, yeah, you know, I have cancer. It's just bad luck. You know, I guess that's just what happens. You know, or people might say, oh, I must have done something in the past. You know, that getting back. I know one of the jokes within my own personal family, I have a brother-in-law. He's a big, tough brother-in-law, and he has 3 girls. You know, and we're always joking with him, going, oh, well, you know, that's karma for you. Now that is something that, and we love my nieces, of course, but it's kind of some of that ribbing that just demonstrates some of those personalistic beliefs of a world where things do happen because of, you know, retaliation for sins, or, you know, just bad luck, or, you know, things that you've done in your life that maybe weren't as you think they should have been. And so often when we're talking to individuals with substance use disorders or mental illness, these are things that we don't even ask about. You know, it's not we often don't ask, well, how do you believe this came to be? You know, why do you believe you have this illness? You know, and others in your family might not. You know, and often this can help us start pulling that out, especially because when we think about the release of and the approaching change and some of the intimidation that comes with it, often these sort of things, our use of even ritual, our daily, what do we do every day? You know, who do we talk to? You know, do you use prayer? Do you use, you know, certain things that you do every day that make you feel comfortable? Those items specifically are often what makes our client most comfortable when approaching change, because some of those things we can keep doing, you know, the ritual things that make us feel good, are important to keep doing while we transition into that change. And that can be really adapting and identifying those cultural things that are going to help that individual and playing on their strengths. So the naturalistic form is looking at that harmony and balance, which is sought in maintaining health and well-being. When there's not balance, illness results. So naturalistic treatments increase metabolic health through diet, exercise, and energy. And I know right now there's a lot of work coming out just on individuals who are starting to look at the impact of diet and exercise on the ability to become well with their substance use disorders. I know often if I have a client who believes that health is going to help them, that I often use this as a first step. Okay, I know you're using, I know right now you may not be ready to change, but you know, I know you said you do want to feel better, and so what would it be like to eat a little better? What would it be like to incorporate some exercise into your day? You know, some of those things, they're very, very simple, but if I have a client who says, I want to get better, I know I need to start taking steps for change, I just don't know that I'm ready to stop using yet, you know, those can be things that we can use when they say, these are the things that make me healthy, make me feel more healthy. I feel healthy when I go for a walk outside. I feel healthy when I, eat something that I know is good for me because it tells me I'm doing something for me. And so identifying where our client feels the most balance and harmony, whether it's a person, place, or thing, that can really help us go, okay, you have that safe place. And so when you're feeling uncomfortable, how do you connect with that safe place? You know, and certainly we can start to integrate, and I'll get to this a little later, some of those, the mindfulness and meditation skills that we otherwise teach into this. If this is where you find harmony and balance, you know, let's use that to start integrating that, you know. And so naturalistic interventions, kind of like I said, they tend to focus on diet and activity. Ayurveda focuses on exercise, yoga, meditation, and massage. And then vitalism, which is the belief that disease is the result of an imbalance in the vital energies. And also often with Hispanic and Latino populations, we also have the use of curanderos, which can be very helpful, or other cultural healers can be very helpful in integrating them into some of our treatment that we're recommending. You know, these things are often things that some of our clients have grown up with, and when they enter some of our agencies, our clinical agencies, sometimes I check the door to see if there's a sign saying, hey, you know, do not talk about any of that in here, because often when they come in and they're looking at a clinician who may be of a different race, different culture, and who has never even asked about these things, you know, what sort of cultural, you know, healers might you use, or what would your grandmother do, you know, what would your grandmother suggest if you were to ask her what would help? You know, asking those questions can allow us to add some treatment interventions that may be very helpful for the individual. And then the biomedical approach is typically a very Western approach, which is the idea that biomedicine is a system of beliefs that's summarized by body as machine metaphor. And this focuses on theory, knowledge, and empirical research of illness in order to advance treatment options. And so this especially, you know, I love evidence-based treatment, and this is really, you know, where a lot of that comes from, going, okay, we know what works, we know what doesn't. Unfortunately, that's both a good and bad thing, because often we can hide behind that. You know, kind of as our second question demonstrated, it's the, if I'm using an evidence-based treatment, and it's with this exact same population that it's been proven to work with, well then for this individual it's going to work. And all of a sudden we've completely lost all cultural competence in that thought. Whereas if we are using evidence-based treatment, it is our responsibility as the clinician to start to look for, okay, you know, here's evidence-based treatment, it's been used with this population in the past, but it hasn't been used with this individual. And with this individual and me, you know, with that therapeutic relationship, how is our view of illness, how is our view of how healing happens and how change happens going to impact the efficacy of that evidence-based treatment? You know, and so I'm going to tell you in a second some of those things that we can change to help strengthen that evidence-based treatment can make the difference between success and long-term success versus, you know, it may work for a short period of time, you know, while the person is supervised and has our encouragement, but they're not able to maintain it, and we lose family support and the support of others. So I'm going to present a framework that can sometimes help us to understand where we can integrate some of these culturally competent interventions. So the ecological validity model was created in order to provide a holistic framework to provide treatment. And so research shows that culturally adapted interventions have lowered rates of premature dropout. And so what we're looking at to create these interventions, and so this is a very specific things that we're developing, is meeting the client where they are requires to understand their concept of health. What do you think about health? What is good health? You know, where do you want to be? You know, when you have good health, what does that look like? But also look at their concept of distress and suffering. What is distressful about this experience that you're having? You know, what about it is most stressful? And then also looking at the client and provider's cultural values. What are my values? You know, I have a long history of life where I've grown up and I've developed certain values and beliefs of what is important to life. You know, it enters into that, almost that, what is my purpose in life? You know, what are my goals? And unfortunately, when I sit in the therapist chair, I can't take that off. You know, and if I'm sitting there with my values and what I believe is important, and I'm looking at my client and going, okay, what's important to you? Unfortunately, no matter what, there's always this, you know, I'm always ranking. And going, okay, well, how does it compare to mine, you know? And trying to, and that's in my goal of empathizing. Often when we're trying to empathize, we try to think, okay, they're sad. Well, when have I been sad? What does that feel like? Okay, you know, can I empathize? But unfortunately, my understanding of sadness, my understanding of being frustrated, being sick, being distressed, may not be the same as my clients. And so that's where we're trying to understand their concept of distress, you know, in that cultural, in integrating those cultural values. And then the last thing, which is, you know, what we like to enter in, because this is kind of what we usually feel stronger in, is that diagnosis and assessment of the provider. And this is where, you know, we're using that evidence-based treatment, you know, and we're using all of our clinical skills, you know, in that diagnosis and assessment. And so in order to provide this treatment, ethnically sensitive, it's, you know, another word for culturally competent, we have to, you know, here's the behaviors we have to do. We have to recognize and express the existence of cultural differences between the client and provider. And so when a client comes in, it's recognizing you and I may be different, you know, and I once had a client, and I always chuckle to myself because, of course, it was after I had started talking about cultural competence, and, you know, so I was feeling kind of, I had kind of a big head, and so I had a client, a Hispanic man, who came in, and it was for an offense that he had participated in. And his family was from Jalisco. My family's from Jalisco. He reminded, I believe, he had many of the same mannerisms. We had many of the same language. We liked a lot of the same foods. We had a lot of cultural similarities. And so in becoming comfortable within and developing rapport, you know, I started to, oh yeah, you know, I felt like I knew where he was coming from, until all of a sudden we started talking about being on time. Now, it sounds like such a silly little thing, but in my family, we always, you know, we have this family joke that we are always late, you know, it's just, we call it Mexican time, just because in my particular family, we are just always running about 5 minutes behind, you know, if not, okay, that's if we're going to work, if not, you know, usually our family parties, you know, they start at 1, everybody gets there about 4, and we're all, yeah, that's just expected, you know. Well, and so I was, you know, kind of going along and talking to this individual about time, and all of a sudden he's like, well, no, being on time is very important to me. And in my head, I just stopped, and I'm like, I've totally missed the boat on this, you know, because all of a sudden I realized that our entire conversation previous to this, I had missed that, yes, even though we had a lot of similarities, we were still very different in terms of our values and our beliefs, and it was because we were so similar that I missed identifying the differences. And so in our treatment, I really wasn't understanding him. You know, I wasn't understanding him like I could, and so, and I needed to listen again as if we were completely different and as if, you know, we shared different cultures, you know. And so it's recognizing that, and research shows we're most culturally incompetent when we are the most similar, because unfortunately we go back into ourselves and we go, I got this one, I know this one. And that's when we turn off our needing to make culturally competent interventions and adaptations. So, and that goes along with the second one of having a knowledge of the client's culture and distinguishing between culture and pathology in the assessment phase, and then modifying the treatment as necessary. You know, so I'm going to talk a little bit about the ecological validity model. And so here are 8 areas in which you can adapt treatment to be more effective with ethnically diverse clients. Now here's how, you know, like I said, you should be considering your own understanding of substance use disorders and mental illness as we go through this. But I'm going to add one more little metaphor that maybe helps you understand. And so often when we see a client walks in, and one of the first things that we start to assess is their cognitive abilities. And so we get that in a number of ways. We listen to them talk. We hear their language capacity. We look at, as we're talking, are they understanding me? And we adapt our language. We adapt the words we use, almost automatically. And so I want to use that example and move it over to culture, because that is what we should be doing. Assessing for culture and adding culturally adapted interventions shouldn't take you any more time than it would be to briefly assess, okay, what is the cognitive capacity? Can they do what I'm asking them based on their cognitive capacity? It's the same question, or similar question, I should say, as does this intervention make sense for them on a cultural level based on what they believe, what they understand, what their priorities are? And so that's really what we're looking. And so, especially as we're always short for time in terms of our assessment, we're not looking to add major amounts of time. We're looking to ask different questions, slightly different questions, or even ask questions in a different way, I should say, and to think about the problem a little differently so that our interventions in the end will be more culturally competent. So the first one here that I'm going to talk about is language. This is one of the easiest ones for most agencies because it's very visual. We can say, yes, we're doing it or we're not. And this includes the actual language, but also includes local colloquialisms and idioms that impact expression. So it provides a communication tool for the speaker to communicate. Individuals are not likely to think of ideas which they cannot express within their culture. If I don't have a word for something, it's hard for me to talk about it. The knowledge of the language usually implies a greater cultural knowledge, and so that's how people see us is if I have language, if I speak a little Spanish, or it usually says, oh, you know something, you bother to learn something about my culture. The importance to Hispanic clients is they can express themselves better in their native language. Using interpreters is always a little clunky, although I know we have to do it in many cases. Local dichos, or idioms, can connect cultural metaphors with the client's experience to increase understanding of treatment concepts. And also, language may also indicate acculturation or assimilation levels. Now, I know I'm going to go through this kind of fast, but I'm going to give you some options as well, which here's some specific things that you can do. Obviously, appropriate translation, interpretation. Providers should clarify any language-embedded meanings that are conveyed through sayings or metaphors, or even words. This week, I've been in my practice, I've been having quite a time with the word perspective. I've been using the word perspective for ages. Well, how do you see that person's perspective? Tell me about your mother's perspective on this. And all of a sudden, I started asking people what they think I mean by perspective, and I realize we're all over the board. So that's my current thing, but every week it's something different of, I've been using this word, and look, it turns out nobody knows exactly what I'm saying. So many theories encourage the naming of experiences of distress and suffering in order to reframe and restory experiences. I love narrative therapy for this, but even when we're using CBT, it's so highly, language is so embedded in that. How do we say things? Thinking errors, cognitive distortions, all of those are based on language. And if we have a client who we're not communicating well linguistically, they can miss the entire point of our work together. So the second one is persons. And so this is defined by the individuals that the client expects to be involved in their treatment and the significance of them. That's really important, the significance. It can mean they're family members, holistic healers, as I mentioned, but it also refers to the client-provider relationship during the intervention. And so for Hispanic individuals, they may place a high value on personalism or friendliness, personalismo or friendliness. They may be more likely to place a high level of trust on one professional instead of relying on multiple specialists. This is often where we have the behavior of they keep calling the same therapist, even though that therapist, may have transferred to them to another therapist, but they keep going. It's like, oh, this is your new therapist. You have to call them. And it's, yeah, well, we trust you. We know we'll rely on you. And so that's because that trust in one professional is more valid or valued. The client may not always express a disagreement to individuals that are in a position of authority, but then they may not follow treatment. If that trust and rapport isn't developed, you might get the false yes of we're all shaking our head, and then a week goes by and nothing happens. And so that's where being able to use that. I'm not the expert of your lives. I need you to help me understand how this will impact you. Is this possible for you to do this? Is this going to do? Would this make sense for you? To engage in this. And so some modifications that we can make are to focus on developing that rapport. Remember, trust is the most important. We can use evidence-based treatment, but if we don't have that trust embedded in it, it's going to be hard for us to move forward. Treatment may include multiple members of the patient-defined family, and it should empower clients with the provider as a guide. And then the provider must remain mindful of the reverent power that he or she has, which is the automatically, because we're in a position of power, we're in charge, there is always going to be a power discrepancy. And so that's something that we always have to be mindful of, because it does change how individuals take our advice. I remember being most surprised. I've had some of them, many of my adults, coming in. Sometimes they don't necessarily want to, engage in treatment or follow recommendations. And I found that I've had experience with some older Mexican men who I say, well, you know what, I think that you should do this. Would this work for you? Well, of course, yeah, I'll try it. And I'm just amazed. I'm like, oh, well, you seem so willing. This is amazing. And they're like, well, you're in charge. You're the professional. You know what I should do. But it's after building that trust, there is that power, and it's recognizing that and being appreciative of it. Well, I appreciate that you trust me with that. So number 3 is the metaphors. So this refers to the symbols and concepts. And so this, often we have individuals who are coming to us, and their metaphor of the American flag, for instance. I might feel great pride when I see that, as it is my native country. Other people may see it as a symbol of oppression, depending on where they've come from or their interactions with the American system. Or they may feel differently depending on their journey of immigration. And so it's being aware of that and realizing my symbols may be different, and even in our agency environments, those are areas where we can make changes, and just be aware of how that might impact them, and ask them, what is important to you, what is symbolic for you, in this, in your approaching change. And so the importance to Hispanic clients, individuals of power may symbolize oppression or prejudice. Often I get clients coming from the criminal system, and this is one area where even as they may have chosen to come to my agency for services, but they were sent there by the court. And so I may be a symbol of just greater oppression for them. And it's identifying how our rapport is impacted by that. Being attentive to these variables help us identify the positive symbols that are helpful and minimize the symbols that negatively impact treatment. So how we can modify this for our Hispanic and Latino individuals is exploring the patient's story. Over and over again you're hearing in this presentation, and I keep repeating the word story, because that story is the context that all evidence-based treatment happens in. My story impacts how I view things. Our client's story impacts how they view things, and this leads to how we move forward and our eagerness to move forward in the interventions. And so the provider has to remain mindful of the differences in the personal involvement, the meaning of the provider. What do I mean to the client, and what does the client mean to me as an individual or family goes through changes? I was just working with an adolescent last night, and I'm the only person in his life or so he claims, that he discusses specific behaviors that he's participating in that he shouldn't be, and so I am a vault of secrets for him, and that's a lot of meaning, and so I have to take that very seriously, even when, discussing it with other people that might be involved in his care, but he doesn't trust yet, because that can impact the people, referring to persons a little earlier, of that he wants involved in his care. And it can impact our rapport going on. So next we have content. So this is one that frequently is easiest to work on, because this refers to just gaining cultural knowledge about the values, customs, and traditions of the population we're working with, I should say. Each client may be influenced by cultural values, customs, and traditions, and I know just the fact that you're here and listening, this is one of your goals of gaining cultural knowledge of, the Hispanic and Latino population, which is fantastic. And so individually, each client is influenced by these things. Regarding the Hispanic population, clients may have unique values, customs, and traditions that connect them to their native countries and to their families. As you see below, the marigold has great meaning for many Mexican families. Being conscious of the impact of cultural content can allow the provider to hear the specific problems and concerns that their clients have in order to address them efficiently. If in my clinical brain I'm thinking, I'm seeing someone for substance use, here's the content, here are the things that we have to talk about, then I may miss the content that they feel that we should talk about. And so some modifications that we can make are, treatment needs to be holistic and may need to incorporate spiritual or other elements from the patient's culture. Remember back a couple of slides ago when I talked about identifying the personalistic beliefs that they have for their illness and identifying the naturalistic beliefs that they have, things that they believe that they need to include in their wellness that we may be unfamiliar with as we're coming typically from a biomedical model. So treatment may incorporate values, customs, and traditions which will increase the amount of comfort and familiarity that the client has with the behavior that he or she is asked to perform. I can ask you, to change, we can talk about cognitive distortions. I can ask you to change some of your thoughts, but if you can't see how this is going to impact the things that are important to you, such as, your relationships with your family, it's going to be really hard to move forward. That is a cultural adaptation right there. It's just including, here's what's important to you, from that cultural point of view. And so next comes concepts, which is referring to the constructs of the theoretical model that's used in treatment. So again, this is bringing in evidence-based treatment, but using the concepts that incorporate the provider's understanding of the problem, and it involves the client's understanding of that same problem, and using the techniques and the frameworks and the theories we have to be able to help our client understand them in their worldview. If the provider and client's understanding of the problem is not conveyed, there may not be an adequate partnership to complete treatment goals. We lose the client. They're not motivated and they're not seeing what might be helpful for me here. The importance to our Hispanic clients are, theories should be used that allow for the integration of the individual's cultural values and beliefs so that they can understand and accept the framework of their problem. And if the client's understanding of his illness is incongruent with the theory, he may not fully be able to participate in treatment. And I'll show you with the next one here. Oh, still have a little more. With concepts, with concepts, some modifications we can make, that's what I was forgetting. When we're choosing a theoretical framework to use, ensure that it's consistent with the cultural concepts of the individual that's being served. And again, I mentioned the cultural formulation and review of the DSM-5 may be very helpful in identifying cultural concepts. One reason I continue to bring that up is because it gives us those questions. How would your family, how does your family describe your illness? How is your illness impacting your family or others in your culture? And that can really help us modify it to meet their needs, their values, and their beliefs. And so with goals, the definition of the goals is referring to the identified desired outcome of treatment. And this is where if the client isn't on board with the goals, we cannot create interventions that are going to be effective because the client doesn't want to go to the same place we are. And so it should reflect the client's and provider's understanding of the problem and of the solution. And so culturally competent care involves you working together. We can't do this, on our high hill of clinical knowledge. So it should be specific to the client's problem, attainable for the client by using his current supports and resources. And this is where, thinking back of many of the things I've mentioned in terms of the strengths of the Hispanic and Latino population, it's using that idea of family. It's using that idea of, valuing support. Those things specifically, are positively research shows that, individuals with more support are typically more successful when it comes to sobriety. And so it's using the fact that the culture values this to integrate it into what research tells us is going to be most effective. And so it must be congruent with the client's cultural values because sometimes, again, there are individuals who don't value that, especially when we look at some of our younger individuals, often they value much more independence. They value being able to make their own decisions outside of their family. And so we still, just because they're coming in, they may be Hispanic or Latino, and maybe even, I have a young person right now that I'm treating that is a Mexican immigrant. However, he came over even as an elementary student, but he still identifies most closely with that idea of independence. So it's integrating that. The importance to a Hispanic client: if a client doesn't feel the goal is worthwhile, his motivation is less, then often due to respeto, or that respect, Hispanic clients may be less likely to express disagreement with individuals who hold positional power. And so if we have goals that everyone isn't going along with, they may be giving us that false yes, and we're not moving forward. And so treatment must incorporate values, customs, and traditions that are integrated into the client's understanding of the problem, and continue the integration of these concepts through the goal-setting process. And this approach will provide the client with an opportunity to integrate new goal behaviors into existing beliefs. So methods are the procedures to follow in order to achieve the therapeutic goals. And so once we're on the same page regarding goals, that's when we develop methods to incorporate the theory. Now, this is using all of the things that we've discussed previously today, but also being aware of that transference and countertransference in the relationship and the use of specific interventions. Is this the right intervention? Is this the right treatment? If we're using CBT, if we're using a brief family therapy, what is going to be best for this client and his or her family? The importance to Hispanic clients are, these are the procedures, and this allows us to be able to actually meet the client where they are and develop things that are going to make the best use of our Hispanics, their beliefs and values. And so the modifications for the Hispanic and Latino culture is they may feel most comfortable using treatment methods they're already accustomed to, and we can encourage them to express their culturally bound behaviors and feelings by ways of methods that they're most comfortable in order to resolve internal and external conflicts, especially when we're talking about those things within a larger perspective of our communities. And then including trusted individuals and offering services in the preferred language. And so really this methods part is integrating everything that we've talked about previously, our language, our persons, our content, our context, into how we're actually doing it. And so lastly, this context considers the client's broader social, economic, and political context, and the context of the intervention impact the client's priorities. And so this is really, once we have, okay, here's what we need to do, the last question we have to ask, or maybe the first one, is what are the client's priorities in completing these tasks? If we're setting the client up, kind of like I talked about, my goal is that you reach sobriety. If I just say, okay, quit using, but you're like, I'm not sure yet, my priority is just living a healthier life, we may have to, work on you increasing your family involvement, participating in exercise, balancing some of your energies before you can start to work on some of the other things that, I may, as a clinician, have as my priorities. And so this is a chart, and I'm not going to go on into it too much, but it's one of the charts that discusses high context culture versus low context culture, which really discusses how we use bonds, how we understand time. There's that nasty flexibility of time, which I made a mistake on, and it really talks about how we use verbal, nonverbal communication. And so, I know this PowerPoint will be posted, and I really encourage you to look at it, in terms of understanding some of these things. We just do, I use a lot of nonverbal communication. Unfortunately, I have that kind of face that I can't help it. Other clients don't use a lot of it, and so it may confuse me, and so it's understanding how context may impact them. If they're coming from a low context culture, which is very open, versus a high context culture where we're looking for some of those nonverbals, which Hispanic and Latino populations come from. They're looking much more for those nonverbals, those relationships, those people bonds. So the importance to Hispanic and Latino clients is it impacts their understanding of subliminal meanings that are communicated. This can make or break, that first 10 seconds of the, the first introduction. The context that you're coming at when you approach a client, this can make or break your relationship often. If the provider does not understand the social environment and economic context, if we're recommending treatments that are economically not feasible to our clients, we're automatically insensitive. That is a culturally competent intervention, when we start thinking about it that way. Easy to integrate, but it's us recognizing that it is a culturally competent intervention. And so some specific modifications that we can make, is it's made up of the client's experience of acculturation. It's recognizing these things, and treatment needs to focus on developing rapport with the client to create an accepting and supportive environment. And so I know I just went through, that's a huge amount there, but all of these things I really want to underline is often we are doing culturally competent interventions all the time in our work, and so some of where we're going is just to recognize, when I take the time to ask, I want to talk to your mother, what is her perception of your illness? That is culturally competent. And so there are things, just like assessing cognition, there are things that we do every day, but part of our goal is to recognize that and then to hone in on our opportunity to understand the individual as a person. So with that, I will close up, and I think open it for questions.
Thank you, Michelle, for a wonderful presentation. I don't know if we're going to have enough time for questions, but just to start on one. You mentioned the cultural formulation interview as a way of assessing culture and some of the concepts related to that. Do you have any other recommendations in terms of really concrete ways that we can approach culture in our interventions?
Certainly. I think much of it is, that first step is really understanding it ourselves and really going through, and one of the techniques that I've used in some of my training is to go through you can use the cultural formulation interview, or really start to recognize the affiliations that you have as a clinician, whether it's community affiliations, culture groups that you belong to. For instance, if you belong to academia, you belong to a church, you belong to a social club, you belong to what generation, and some of it is really taking the time to explore some of those things, and that can help you start to pull apart even, those 8 things that we just mentioned, and putting in some reflection as to how do I, what are the metaphors that I use to describe substance use and illness in my life. Doing that, we can often start to understand and approach, understanding what we might think, and then it gives us something to, when we're working with clients, going, okay, here's my bias, here's my understanding of what it is, and that way it's the idea of, as I said earlier, culture is like skin. We don't feel it until it rubs up against someone else's. It's recognizing our own skin. So when it does rub against someone else's, we go, oh, yours isn't a problem. It's going, we both have skin. Let's talk about how this feels. If yours is rough and mine is smooth, and how that works. But if we don't understand how our own skin is, it's hard to recognize where other clients are coming from.
Mm-hmm. Thank you. So one of our participants is curious, what is the significance of the marigold flower?
So within Mexican culture, we often use that during Dia de los Muertos, and often during many of our traditions, and so it's thinking about that marigold, which, I've used in my family. At least it's very important, maybe not everybody. Can only speak for myself, but even that marigold, recognizing that might have significance for me, in terms of recognizing my ancestors, people that have come before me. When using that flower, maybe in interventions that I do, in pictures, maybe I draw about my illness and things like that. And so that's just an example of symbolism, of using those cultural symbols as we go through that healing process. Some of the homework or assignments or activities that you have in your treatment programs, often have that self-reflection, and it's asking clients, share with me that symbolism that right there could really open up. Tell me about your experience with loss. Tell me about your experience with losing people and with change. That could really open up some great opportunities for discussion.
Okay, thank you. We have another question. If the effective use of language is a barrier for my program and we don't have the ability to translate an entire intervention, what tools can we use that could support the clients?
Okay. No, I'm not. I don't believe you're asking about maybe language tools, because there's all sorts of, you know, different things. There's all sorts of assessments that are translated into Spanish, and, you know, I mean, many of those are publicly available. But as with, when we're looking at any of these interventions, we look at them in groups, and so ultimately your agency will not be good at all 8. There are some that, because of the way your treatment program is, you can't invite a lot of family in, you know, or because of time you don't do family treatment, or, you know, which is unfortunate. And so it's recognizing that all 8 of these interventions are important, and so if there's one, obviously language is so important, but if, you know, because of how your agency is set up, it's one that you struggle with, then it's emphasizing the other ones. You know, it is, okay, you know, you know, bringing in family, or it is making sure, you know, please, you know, express to us the symbols that you use, or, you know, focusing on that goal development, you know, in terms of where they're coming from. And so I see all of these 8 kind of different areas of interventions as equal. Language can certainly be a barrier, but they should be equally considered as, you know, all 8 should be equally considered, and unfortunately that language one, it's usually the first one we notice on entering the door, and at that point, if we can't accommodate it, we kind of just throw up our hands, and it's like we can't do anything else that'll be culturally competent. But I always challenge people, look at some of the other ways that you can make this culturally competent, you know, because I know sometimes we don't have a lot of resources.
Mm-hmm. Thank you. Excellent presentation. Thank you so much. If we have more questions, what we'll do is we'll send them to you so that we can post the answers along with the recording of the webinar and the PowerPoint slides. I know people are interested in those. So
wonderful. Thank you so much.
Mm-hmm. Let me go back here. Okay, so oh my screen. Thank you so much again for your presentation. As I mentioned before, a recording of today's webinar along with the PowerPoint slides will be posted and available at our website at attcnetwork.org/Hispanic Latino. So we'll have that available. Here's the address for those who missed it and want to write it down. Okay. So this concludes today's webinar. Again, I would like to thank our presenter, Dr. Michelle Evans, and remind our audience that you're interested in receiving further training on this topic. You may email us at hispaniclatino@uccaribe.edu. And please look at our website to learn about future webinars. As you leave today's webinar, you'll be directed to complete a brief survey about your experience. Your feedback is very important to us, and we appreciate you taking the time to tell us what you thought of today's webinar. So again, thank you, everybody. Have a great afternoon.
You too. Thank you.
Thank you, Michelle.